We're going to get started right about now. My name is Rebecca Kiesling, and I am the Director of Programs at Benjamin Rush Institute. That means I have the great job of working with medical students and doctors in our chapters. BRI has been around for close to 10 years now, and our mission is simple. We work with medical students to promote free market healthcare alternatives that are not being taught in medical schools, primarily because those medical schools are being funded by big business, big government, big insurance, big pharmaceutical companies. We have 40 chapters, over 40 chapters throughout the United States and internationally. We are so excited about today's event, rounding out our June calendar for our virtual event series. Moving to all virtual events has been pretty seamless for us, as we've been streaming events between our chapters for over 2 years now. We record all of our events, so if you'd like to view any previous ones, please go to our website and check them out. You can also sign up for our newsletter to get information about everything coming up in July. Part of progressing the doctor-patient relationship, which is part of our mission, is ensuring trust. This trust is difficult to achieve when patients rarely know what they will have to pay for before they have any medical services. This means patients cannot make informed decisions about the value of the care that they receive. The debate on price transparency is one of the hottest topics today, as rising healthcare costs due to COVID-19 is putting a further strain on all Americans. The American Hospital Association recently lost a legal bid to stop the Trump administration from requiring hospitals to publish their negotiated rates with insurance companies. At the forefront of this debate is David Balat. David is the director of the Right on Healthcare initiative at the Texas Public Policy Foundation and the dedicated head of a coalition of patient-doctor relationship-focused organizations that BRI is proud to be part of, called Free2Care. He has broad experience across the healthcare spectrum with special expertise in healthcare finance. He's a former congressional candidate and a seasoned hospital executive with over 20 years of hospital executive administration experience. David has testified before the U.S. House Committee on Oversight and Reform and before various House committees in the Texas State Legislature. He's published op-eds in The Hill, Real Clear Politics, and other news outlets, and an active speaker and commentator on all matters of healthcare policy. Because we are streaming this live on multiple online platforms, I welcome everyone watching today to use the chat or comment features as you're watching to ask questions throughout David's talk. He is on the road in St. Louis about to testify before the Missouri Legislature, so you're going to see him in a car. So we're going to take those questions in. I'll get them back to David later. And I am thrilled to turn this over to Dave, our guest today, my friend David Balat.
There we are. I think we're in good shape. I am in a car, but I am not driving. So don't be too worried about me. Thank you so much for this opportunity. I'm really honored to be on this program with you. Benjamin Rush Institute is a very important organization, and it's an important organization as a member organization of Free2Care. We are very happy to have the medical students and the folks that support Benjamin Rush be a part of the advocacy in that organization. It's very important. Our number one issue right now is transparency, and rightly so, because what Rebecca said was correct. Ensuring trust, something that unfortunately we're losing in healthcare. And although doctors are still some of the most trusted individuals for patients, it's taken a beating, and not necessarily because of the actions of the physicians, but because of the system overall. The lawsuit that Rebecca alluded to, there was, let me start back and back up just a little bit. The Trump administration had put together an executive order that was put out in middle of last year in 2019. It was to have people be able to see what the real pricing is in healthcare. So let's talk about what real pricing means versus the standard charges. In hospital, you've seen these crazy charges. They come off of something called a charge master, but they're the gross charges. These are astronomical numbers that everybody complains about. Those aren't the real charges. The real charges end up being what is negotiated with the insurance company for a particular plan, because that's what your benefits then apply to. So let's work off of a real world example. So let's just say I have an Aetna plan. I don't have Aetna, but for the sake of the example, and I have a $5,000 deductible, and I need a CAT scan. That's CT of the abdomen without contrast, and I need to go. And Hospital A and Hospital B both have same procedure, same radiologist. Everything is exactly the same. One hospital's gross charge is $5,000. Hospital B's is $10,000. Does that matter? No, because in Aetna, Hospital A is a one-off hospital. They're the only one of under their name in their market, and they've been able to negotiate a rate on the lower side of say $700. Hospital B is a system. They have more market leverage, and they're able to negotiate much better rates of say $1,500. Now, those prices are the real prices. If you don't see those prices, how does a patient know, and how does a doctor know to direct their patient to the service that will offer the more affordable price? Because you're looking at an $800 difference. $700 versus $1,500 that's a lot of money to a lot of people. And remember, the services are exactly the same. So that negotiated rate becomes the real price from which your benefits are being reduced. So if you haven't met your deductible, you're paying out of pocket. You're a cash payer, which with as many high deductible health plans are out there today, we are healthcare shoppers. Now, even if you had met the deductible, let's just say you've paid out your $5,000 before you needed the CT, you would typically have a coinsurance. A coinsurance would be a percentage. So typically, if you're in network, it's an 80-20 plan. So the patient would be responsible for 20% of the negotiated rate. That's still a huge difference. And so, of course, if you're getting like services, like quality, why wouldn't you want to get the more affordable rate? The insurance companies and the hospitals said, no, our charges, our big gross charges, those are the standard rates. Those are what we should have in the marketplace. If we had those other things out there, that would be too confusing. It would cost us a lot of money, and it would increase the cost of care. I love the fact that they think prices would confuse the American people. I think we would do okay. We tend to do all right with just about everything else we do. But for some reason, they think that would be much more complicated. There are a lot of people out there that would agree with them. They would say, all this, there are too many CPT codes, and the ICD-10s are confusing. But you know what? That's a system that we've unfortunately had to acclimate to. Does it need to exist? Absolutely not. And you've seen physicians and facilities break from that mold and do something unique and do something new and do something that is both of good and high quality and that is extremely affordable. If you haven't heard of, let's just talk about surgery. The two great examples I have to represent in Texas: the Texas Free Market Surgery Center in Austin with Sean Kelly, and then my good friend Keith Smith, Surgery Center of Oklahoma. These facilities have bundled pricing. So if you need a hip replacement, an ACL repair, you name it, you go to their website and you'll find all of the procedures that they offer. I've even asked them to put together a bundle for something that they didn't do, and they were able to put that together. So, but it's nice because it's one single price for the physician, for anesthesia, for facility, for implantable, everything. You know that price, and you pay up front, and you walk away, and their quality is outstanding. Looking at physicians, direct primary care, people that are posting cash prices, people that are saying, here are my prices, and if you would like to bill to the insurance, I'll get you the information, I'll get you the documentation that you need to do so. But direct primary care is a membership model. It's a completely new model, and it's effective, and it's growing, and it's representative of that doctor-patient relationship, which is something that we've lost in healthcare and that we need to get back. And that's going to start with all of us, and that's why Free2Care exists, and that's a big part of the mission of the Texas Public Policy Foundation in our division, which is Right on Healthcare. there have been too many middlemen that have injected themselves into that relationship, and they're extracting a lot of value, and that's costing more money. And it's really hurt that relationship, which is fundamental to what it is that you all offer, which is the practice of medicine. So going back to the lawsuit, it went to a district judge, and Judge Nichols did say that we are going to dismiss all of your arguments. And Free2Care did provide an amicus brief to defend the defendant in that case. And we're thankful that we contributed to that big win, because the insurers and the hospitals lost substantially. And they've already signaled that they will be appealing. They do not want to release that information because prices will come down. When you list your prices and other entities see those prices, and you have patients that are cash payers that then become shoppers, you're forcing those entities in the market to compete. And when they're forced to compete, what's going to happen to the prices? They're going to go down. So we need to do these things to ensure trust. I applaud the president's executive order. I would love to see members of Congress codify that order, because executive orders, as you may or may not know, they come and go depending on what the next president wants or doesn't want. It's an interpretation of existing legislation or existing law. So it needs to become a part of the fabric of healthcare. We cannot have a market-based economy if we don't have those signals that are so important, which are the prices. So let me ask Rebecca to see if there are any questions so far, and we can talk a little bit further based on what people are hearing, like to see.
So I have, with bundled hospitals, what happens if you encounter an additional health issue? Example, you had surgery done while in the hospital, you contract a sepsis infection. Does that bundle include that treatment?
I don't know what those organizations do, but I do know. Let's talk about health insurance, because a lot of people think that I hate insurance, and that's just not the case. What we have today is not insurance. It's insurance by definition is a transfer of risk. And there's no transfer of risk when you've got the average annual premium of I think $24,000 is what the Kaiser Family Foundation said was the average around throughout our country. That's a huge investment. And in fact, that's a brand new Volkswagen Jetta every single year. Every single year. Think about that. And that doesn't even touch your deductible, which is on average between $4,000 and $6,000. And then your co-insurance beyond that. And then you have an out-of-pocket maximum. So you're looking at $30,000 plus before really insurance is kicking in. So we need insurance, health insurance that is really functioning like health insurance. And health insurance addresses those catastrophic unplanned events. And so having something terrible happen, like contracting sepsis as a secondary infection, that's when that would kick in and be applied. But for the initial procedure, in that bundled case, it can be much more affordable. And let me just share one quick story. I think Keith had put this out. There was a woman in Georgia. This was a story on the Patient Rights Advocate website. And she needed a surgery, and the hospital there in Georgia quoted, I think it was $40,000 plus. And I think she was part of the employer self-funded plan, so she wanted to shop and make sure she was getting the best deal. She found Surgery Center of Oklahoma's website and found and called them up and told them what she needed, and they quoted her $4,700, all in bundled price. She went back to the hospital and told them that she was going to Oklahoma. Guess what their response was? We'll match it instantly. So how do you think that would make her, how do you think that made her feel? How would it make you feel? Does it make you feel that you were given the best price possible? Does it feel that maybe you were taken advantage of? It sure would make me feel that way. And I'd still go to Oklahoma personally. I think she stayed in Georgia. Rebecca, what's next up?
So this is from a patient. We have, like I said, we have a great group of people on here. Can we as patients not get a list of doctors or providers who will be treating us in advance, so we can say if we prefer to use someone within our network or Medicare approved?
Can you get a list of people who will be, that's part of the transparency. Yeah. It's when you go into surgery, people know what's going to be happening in surgery. But going back to these organizations that have bundled prices, there's no surprise. What you pay is what you pay, and there's no additional bills that you'll be getting. I would love to see more facilities get into that. It's something that can be done. I've run hospitals. We could have done it. And we did, and we tried, but there was just a lot of pushback, especially from the insurers and some of the employers. There was just so much inertia that it was difficult to get out to make happen. And that's part of the reason why I no longer do what I love to do, which was be a part of the supporting physicians in the delivery of healthcare in a hospital setting. But you should absolutely ask and say, I want to know who's going to be in that room, what they'll be billing, what their price is. That's where we're headed. That's not where we are today. And unfortunately, that's the business plan of many of those organizations. Is they're out of network and they don't want you to know that they're there or what their prices are.
So this is more of a comment about reimbursements, and I'm not, talking about reimbursements. We talked about reimbursements a lot about when we were talking with Marion Mass, with Dr. Mass, who was fantastic a couple weeks ago. But almost everyone who's doing direct care has opted out of Medicare and does not accept reimbursements from third parties. Network is kind of a dirty word. What do you think about that when it comes to transparency?
Well, I think transparency is needed throughout. I'm not sure I understand the question completely, but are networks needed? A network is derived by the insurance company. They've created a miniature market unto themselves that they control, and they're able to use the carrot and the stick. Unfortunately, most of the time it's a stick as opposed to a carrot. But who does it hurt? It hurts patients. Would we have surprise billing today if it were not for networks? Surprise billing comes from out-of-network providers. If we had transparency and the ability to compete on price, you wouldn't even need a network. I mean, just think about the failure of the networks. Look at the ACA, Obamacare. If there's not a single ACA plan that has the top 3 cancer centers in the country, MD Anderson, Sloan Kettering, and the Mayo Clinic. They're not on there. They would have to go out of network if that's the care that they wanted. So, and that's atrocious. You should be able to, if I felt, if I had a loved one that contracted something, I would want to get them the best. And unfortunately, even with insurance, I would have to go out of pocket in that particular example.
That's what we have for questions right now. So okay. I'm going to go with what I always ask, and you knew this was coming. One of my things that I am just so passionate about, I'm going to come back on screen. One of the things that I'm most passionate about with our students is advocacy. I think that once our students get that MD or DO after their name, they become just so powerful. As we have seen with Free2Care, but in all of our work, not all the students are, and even our doctors are not always comfortable with being loud with their voices. What can students do? But what can doctors, what can patients do right now to further this? We're at such a unique point in time. Where there's ability to have so much movement. What do you think the next steps are?
Sure. If I may, let me speak to the medical students and the physicians initially, and then I'll bring it out. Why did you start down this road? Most of the time, the answer is, from what I've heard, I want to take care of patients. I want to be. I'm a caregiver. I'm a healer. I want to give back to my community. Those are all genuine and honorable responses, and I applaud you if that's you. The best thing you can do is stand up for yourself. Be independent if you can, because once you go and become employed for a big system or an insurer, your ability to be independent is very, very difficult. In terms of advocacy, what you need to have your lawmakers, you don't necessarily, let me start over. It's not just important for you to know who your lawmakers are. It's important for your lawmakers to know who you are and to who you are affiliated with. That's why Free2Care has become such a loud voice. 29, almost, well, on the way to being 30 member organizations, over 8 million people nationally, including 70,000 doctors. People in DC know who we are, and that's good. But I want them to know who you are. Go to your city councilman, your state reps, your state senators, your congressmen, your senators. Go visit with them. Let them know who you are. Meet with them, and give them your cell phone number, because if they have questions, they may call you. I will tell you this: most healthcare experts have never worked in the industry, and they really don't have a depth of expertise. They have maybe a breadth of it, but the depth just isn't there. So don't be intimidated by those that refer to themselves as healthcare experts. Many people in government do not really understand healthcare and the way that you all understand it at the point of care. That's something that unfortunately is foreign to them. What else can we do? You're already a member of Free2Care. Go to our website, free2care.org. And right now, because of our push and transparency, there's a take action button. You can go to that button, click it, go to that link, fill it out, and you'll be sending an email to every one of your representatives in the area that you live. I would encourage you to do that, and I'd encourage you to send that link to as many people as you possibly can. We try to do a lot of the work for you that is consistent with our platform issues, which is also on the homepage. But you can learn more about us there, and you can also reach out to me if there's any interest, or you could just reach out to Rebecca. She knows how to get a hold of me.
So I knew this was a leading question when I got it, by the way. I'm supposed to ask you, who shared the Georgia and the Surgery Center of Oklahoma with you? I'm letting you know that your Georgia boy is on the question.
Goodness. You know, if I cared enough about college football, I could get into it with him. But I think, well, I guess it was him. If it's leading that much, he may have been the one to tell me. Mr. Carl Schuessler there in Georgia.
That is exactly who it is. Yeah, I knew it was leading when it came in, and then he told me. So, what else could we? Where do you think? I did appreciate those your answers to those questions. I thought, or to the advocacy part. We are partnering with the Leadership Institute to do some leadership trainings or some advocacy trainings, which I think are going to be great for the students. I think it's just vitally important to, at all times, but I just think this is a great moment for us to be able to influence some really big changes in where healthcare policy stands. It's going to really impact the future of healthcare policy and healthcare and medicine. Something I say to all of our guests is that it's a really telling point for the future of healthcare when the AMA reported that on the very first day of medical school applications this year, they had 60% more applications than they did in 2 previous years. And it's the very first day, so that you don't quite know where it's headed, but it's our moment to really impact what the future looks like. And if we can tell those students what healthcare currently looks like and how that's going to impact their profession, then we have a real chance to change. So I always ask that question, what does advocacy look like for them?
Yeah, it's what let me tell you what a lot of patients see and how they feel. They're frustrated. They go to the doctor. They can only come in with one, maybe two diagnoses. The doctor is entering data in a computer, facing away from them. It's just not. The way that it used to be, which is why a lot of people end up going to urgent care and emergency care. I have personally, I live what I preach. I have a direct primary care membership for my entire family, and I also use a medical cost sharing plan for anything catastrophic. And I'm happy to share with you the prices combined, which is 24/7 access to a primary care physician, and the coverage should anything bad happen to me. I pay less than $500 a month for a family of four. Now, the equivalent of what that deductible would be for that coverage is $1,500. So there are good options out there. Healthcare can be affordable today. It's just a matter of how we look for it. And so physicians and other advocates for patients, we can navigate them. That's what they want. They want healthcare is confusing. It's complex, and they're told one thing by this person and another thing by this person, and they need a quarterback. So that's where I think that we need to go, and the direction that we need to go in. And when we go talk to these lawmakers, it's not necessarily the way that it is today. It does not have to continue this way. We can envision a new future, and that's okay, and it's absolutely necessary. Let me tell you just a quick story. I went to go meet with a congressman, and I sat with his healthcare expert, and this person was very excited about this graphic that they made that they felt described or defined the healthcare industry. And it was a triangle. And one point of the triangle was the insurance industry. The other point was the hospital industry. And the third point was the pharmaceutical industry. And they're looking at me for my response, and I nodded my head a little bit and said, "Where's the doctor and the patient?" They've lost sight. And there's just a lot of money involved with those organizations. They're throwing a lot of money at those individuals and those campaigns. But that money is used to acquire voters. And that's why we're trying to grow our numbers, because we're voters. And we want to be able to influence decisions by saying all of this, this organization, which represents all of these folks, and the physicians and the patients that are the basic building block of what we consider healthcare to be, which is that relationship between those two parties. We want a different environment. We want something fresh and new, and we are going to be a part of that change. And you can come with us, or you can continue to fight us.
This is going a little bit outside of what we were talking about, and well, kind of. How can we fix this archaic healthcare system? So, nice and small.
Is that a question?
It is. Transparency is great, but we need quality metrics. What are your throts?
Oh, sure. Yeah.
Throw it out there.
Let's fix medicine. Let's fix healthcare.
Fix it right now.
Yeah. It's important to understand what's going on in healthcare. There are so many layers. A lot of people don't know what's going on. And I would encourage you to go to our website at texaspolicy.com, and we have a ton of research, a lot of commentary. And then at texaspolicy.com/ROH, you can sign up for our newsletter, and we'll put out information on what we've distributed. I've got a lot of things to say. I'm in a place of pause. transparency is the first step. We have a long way to go. I am opposed. Everybody is saying, well, in the healthcare debate, everybody's now talking about the ACA, and I think there's a vote today on supplementing the ACA and boosting it and making it bigger, which insurance is not healthcare, and they continue to conflate those two terms. And many on that side will say, well, David, what is your plan? How are we going to replace this? What will we replace this with? And if I answered that question, I would be guilty of what I tell them is inappropriate. Healthcare is hyper-local. It should not be run. There should not be a plan. We just need to fix the damn industry. We need transparent pricing. We need people to be independent advocates for their patients. We need good costing in our facilities. We need to eliminate the need for networks that limit patient choice. We need to have the ability to use our own money in a tax advantaged way, so that we can purchase services as opposed to going through an insurance company that somehow makes it more expensive. So we need to be the ones that have control of our own destiny in healthcare. Many people just feel like cattle at this point. They don't know what to do. They're taking cues from their insurance company as to who the list of physicians are or services that they can choose from. And then it never really works out the way it's supposed to, because then we have an issue with surprise billing and so on and so forth. So I don't think that there is a thing or a plan that should be endorsed and put forward. I think that there are a lot of structural reforms that we need to introduce and make happen. You look at a great example. One of the things that both organizations, but Free2Care is, and Marion probably talked about this, price of medications. Pharmacy benefit managers. If you're not familiar with that, there's a touch point document on the Texas policy site, and we've created you can look at all of the entities involved in the distribution of medication on the outpatient basis. 2/3 of those organizations never touch the product. They also happen to get 2/3 of the revenue, or they keep that. They're keeping that money. There was really no need for all those organizations. Look at a great example is Humalog. In 1996, it was $36 a vial. Today, it's over $300. It hasn't changed branding. It hasn't changed the bottle. The formula is the same. Nothing has changed. You know what has changed? The pharmacy benefit managers in 2003 got a safe harbor that allowed them an exemption from the federal anti-kickback statutes. I'm going to repeat that. They got an exemption from the anti-kickback statutes. And so they've changed their business model, and in order for the pharmaceutical companies to get on the formulary, they have to give bigger and bigger and bigger rebates. So we just have a lot of work in structural reform. We don't need another plan. We don't need expanded coverage options. We need to focus on making healthcare affordable.
What is next for Free2Care? So if we're working on, we've transparency. I mean, where are we going next, or what is next?
We have from the same executive order. There was some language there that the White House put in for HSAs, and so the HSAs, and they were waiting on comments and rules to come from the Department of Treasury and the IRS. IRS has not traditionally been friendly towards direct primary care or sharing ministries. So Free2Care will be submitting a comment, and we'll be putting that together, and we'll publish it on our site and give you the opportunity to submit that comment to the federal government to say that direct primary care is not a form of insurance. It's not a form of coverage, that you can use your HSA dollars to contribute to that membership, that should be a qualified medical expense, which is the language in the HSA rules. And you should be able to use those dollars for Christian sharing ministry as well. Now, there are some very good bills out there. Congressman Chip Roy and Senator Cruz have, I think it's H.R. 5596 and Senate Bill 3112. And those actually decouple, because you cannot have an HSA, a health savings account, unless you have a high deductible health plan. And so their bill seeks to separate those two. You can have an HSA and then you can just use it for qualified medical expenses. And that's what we would like to see. I would say that's our next step.
And do you think it's going to be this session? Because it's gotten kicked, changes to DPC and HSA. It's gotten kicked back a few times. So,
are you talking about the comment or the
Well,
bills?
the comment we know is going to have to be this session. So,
yeah.
What do you think is going to happen after that? So we'll get the comment in, and
yeah, and so I'm an eternal optimist, but it is difficult in a divided Congress.
Yeah,
because a lot of unfortunately.
I'm asking for the crystal ball. Come on.
Sure. It depends on who wins in November.
I guess that's where I was going with it.
Depends on vote. It's incredibly important.
So. Why are you in Missouri?
I was invited to come give testimony before their House Budget Committee. They're having a discussion on Medicaid expansion, and giving my 2 cents on that, and whether that's a good move for the state.
This is a good one. Here's a great question. And this goes into one of our talks for next month. We are going to be speaking with Mercatus is going to be doing something for us on rural healthcare. So rural hospitals need help. Any thoughts on what we can do, i.e. 450 rural hospitals at risk of potential closure? We need a plan for those struggling rural hospitals. Do you have talk on that?
I do. We just we're in the middle of some research regarding that, actually. Texas, as you may know, is the unfortunate leader in the number of hospital closures. What we have found is that the majority of those closures have come in counties with populations of 20,000 or less. And over time, there's been outmigration from those counties into the more urban and suburban areas. So the question is a hospital necessarily the best form of care for that community? Can we right size it? Does it need a community health center? Does it need, a federally qualified health center? Does it need, whatever it is? Typically, in the hospital, we would do a needs assessment based on our primary service area. And I have a wonderful example of what it is that I'm talking about. If you look at Fort Scott, Kansas, which I'm closer to there than I am my home state at this point, they lost their hospital. It was devastating because it was a community hospital. But what did they find out? A year later, they said, you know what? We really didn't need that hospital, because they had someone come in and take over the ER. They had a federally qualified health center come in, and they said, you know what? We're actually doing better because now we've got behavioral health. We've got the ability to have the ER stabilize and transfer if somebody needs to get to a hospital in an emergent fashion. They can get their medications at a much more affordable rate. So it's ended up being a positive thing for that community. And if you hear me talk for any period of time, you're going to hear me say that coverage is not care. We need to stop focusing on insurance. We need to stop focusing on buildings. We need to focus on meeting the needs of patients where they are. And those needs are typically met by medical professionals. So I'll leave that there. I think that there is more that we can do by learning our communities and meeting their needs where they are. Because looking at Texas, it's so diverse, culturally, economically, educationally. To have a one-size-fits-all situation is just, I think, detrimental and unkind to the community.
One of the things I recommend to people, I get the question often, how can I get information from our speaker? I recommend highly you go to texaspolicy.com, you go to free2care.org, follow David on Twitter, David Balat HC, right? I'm pretty sure that's, yep.
Yep.
You know, if you're on LinkedIn, the information that David shares is wonderful. You're going to get some really great quality information. It's the information that we recommend that you start to follow. I share it all the time off of our Twitter account, off of LinkedIn, off of those kinds of places, off of our Facebook page as well. It's the kind of information that, especially if you're interested in these kind of topics, and, you know, in transparency, in, you know, the free market alternatives that we've been talking about here. These are the kind of people, you can look at the kind of people that he's retweeting as well. Start that kind of following, because you're going to get some really top quality information. You'll hear back on our previous speakers, the people that they have mentioned as well. Some of those blogs that the different doctors have talked about. Start following those people, and you're going to find just some really great information. The places they write as well. That's always something that I was getting asked as well. I want to just definitely recommend and keep reiterating that. So, what else can I ask you today?
Well, I did want to say this, Rebecca. If anyone has a question, just a pressing question, or if it doesn't have, it doesn't have to be today. It could be, a couple days from now, and they have just a burning question. Please have them reach out to me, and I respond. I answer my questions as long as you're nice. I respond.
Of course, I did just give your Twitter account, and we all know that Twitter is always the nicest place.
Please, yeah, well, but I respond to the nice ones. We all started a Facebook page called Right on Healthcare, and that's become a very dynamic group. It's patients and doctors. There's a lot of doctors, and we talk about some of the things that we've talked about here. But it's we're trying to build a community of people that can uphold and support each other.
Another question: how do we get hospitals from turbocharging their rates?
Transparency. That's really it. Why do you think that they're fighting so hard? Why do you think they just launched a massive lawsuit against the U.S. government, lost royally, and now they're about to engage in another very expensive appellate fight? Why are they fighting so hard? They don't want their real prices. They don't want it. They don't want people to know. They actually look. They've insulted all of us. They said if we posted those prices, you guys just wouldn't understand it. And again, I'm offended for myself and all of you. But that's a simple answer to a simple question.
Well, my information is going to be at the end of this, as well as BRI's. And if anybody would like to get in touch with David nicely, then you can contact me, and I will definitely get you in touch. I do recommend, following Free2Care, following Texas Policy, getting in touch that way as well, and making sure that, you read the white papers on both of these pages. There are advocacy tools on them. Get involved. It's really powerful stuff that will impact you as patients, and will impact you as practitioners as well. So BRI, we are thrilled to be a part of Free2Care. And I am very thankful for you and everything you do, because you keep running. You keep the wheels going. So thank you so much, David Balat, and good luck today in your testimony.
Thank you. One last thing I'd like to say: the Twitter account for Free2Care is Free2Care, free number 2 care HC for healthcare. And I also want to say this: I haven't had any of them volunteer, but I know that we have a lot of really passionate physician advocates. And if someone wants to get hooked up with some of them, let me see if I can match them up to where they can learn from someone in their own profession. I'm happy to help and support, but I'm not a physician.
Absolutely. I mean, this is a great group that we are part of, and these physicians want to mentor. They want to be advocates themselves for their professions. I mean, you could hear the past few doctors, they just love being doctors. And that's why they are so passionate about changing the profession for the better. So yeah, absolutely. So that's why we do what we do. So thank you. So I'm going to say thank you so much, and put my contact in for my healthcare information. No, my contact information up at the end of this. Thank you so much, David. Good luck today. And thank you all for joining us. Sign up for our newsletter at benjaminrushinstitute.org to be notified about what our July events are. And Free2Care.org, TexasPolicy.com, and find all of our information. So thank you so much, David.
Have a great day.
You too.